Good afternoon. I am Dr. Ajay Sinha. I come from Patna, Bihar. This morning I spoke on the topic of lipid profile, non-fasting. It's very interesting because generally whenever we ask the patient for lipid profile, the patient would come with a fasting to 8 hours or so. But this is the time we have to change our mind, because many a times the patients who are coming to us not fasting or any time of the day, blood sugar should be, fasting lipid profile may not be possible, and then we have to go for non-fasting sample which is adequate as far as cardiovascular risk assessment is concerned. And there are a lot of evidences now, right from 2009 to 2017, 18 even, which says that fasting is not required at all because the difference of triglyceride after meals is hardly 26 milligram, whereas difference, that is fall of cholesterol and LDL after meals, is about 8 milligram. So there is no much difference. In addition, we have another big advantage of taking sample in a non-fasting stage, because the non-fasting samples, the contribution of intestine, the cholesterol, lipoprotein goes into circulation after absorption through the intestine, and that forms the complete profile of lipoproteins which are atherogenic. So if you want to take an atherogenic component of lipid profile, you have to take it non-fasting. That's very surprising. So my message is very clear that unless triglyceride is pretty high, more than 400, you just go for any day of sample, day, afternoon, morning, evening. That is equally good, and that is now evidence-based. I would say that non-fasting is evidence-based and fasting is not so evidence-based. Thank you.
I am Dr. Dhiman Kahali, Senior Consultant Interventional Cardiologist, PM Birla Heart Research Center. And I have with me Dr. Ajit Mulasuri, who is a very known figure, and he is a great cardiologist, and he has introduced the STEMI system all over the Tamil Nadu. So Ajit, we see in our country that patients have heart attack and they think we have gas, we have acidity, and they take antacids, pantoprazole, ranitidine, etc., etc., and they come much later to us. Even concerning us, the doctors, we are sometimes little reluctant to send the patients early to the hospital where there is cardiac facility and it can be done quickly and in an effective way. So after implementing the program in Tamil Nadu, how do you feel that anything more can be done about it in Tamil Nadu? And I am talking about the greater Indian perspective, that how we can introduce, because Create registry, Kerala registry, everything have shown that the patients come to us average more than 6 hours, 5 to 6 hours after the onset of chest pain. And our experience is that sometimes they come even later, means after 12 hours, after 24 hours, and European Society has therefore recommended that for primary PCI you can extend and go up to 24 hours, or if there is ongoing chest pain you can go up to 48 hours or even after that. That's a class 1A or 2A indications. So what is your message to the doctors, to the patients in general, that what should they do to know about the disease and to subject them to the medical care as early as possible, that is during the golden hours as we call it?
Thanks, Dhiman, for that brief issue-based discussion you had. The first part of the area is the recognition of chest discomfort, and this is a global phenomenon. It's not an Indian phenomenon. People tend to believe that they don't have a heart attack, and even among the doctor community they seem to underplay the symptoms. So this has to be addressed by a large public health effort, which is basically speaking about the problem that symptoms that look like gas are not necessarily gas, it's heart attack. You should go to a hospital. But what I have to say, that's the most difficult part of the whole thing. The American Cardiac Society and the AHA, along with the government of the US, have spent billions of dollars, but not been able to reduce the time from the discomfort start to access to a hospital to less than 120 minutes. European countries have brought it down much lower, but in the US it still hovers around 100 to 120 minutes. So I think that's one part of the story. But once somebody has chest pain and calls for an ambulance, in the Westernist society, you will have the ambulance coming in about 5 minutes, an ECG taken, and treatment initiated immediately. What in this country we do not have is this system of care. So what we did in Tamil Nadu was basically got what we call as now called as the STEMI India, or the hub and spoke model, where there are small hospitals which are surrounding big hospitals. The small hospitals could be small healthcare clinics, could be small government hospitals, could be district hospitals, which have a basic ability to do an ECG, and some of them will have a coronary care unit. So what we have tried to do is a public health sort of initiative of trying to disseminate the knowledge that if people have chest pain, please access a hospital. Once you go to the hospital, then once an ECG is done, then care is immediately started. The blood thinners like aspirin, clopidogrel, statin is given. And then if the patient can be shifted to a bigger hospital within 30 minutes, which is not usual in this country, except in parts of India, you will thrombolize the patient, which is the best way to treat these patients. And once the thrombolysis is initiated, then you immediately start thinking of shifting the patient to a major facility.
At this point, just I am intervening. Have you got any fascination for any particular thrombolysis? That means streptokinase or the newer generation like tenecteplase or retiplase, and what difference you have found? Is there any difference so far as mortality is concerned? Because there is a huge difference in the price of streptokinase and the newer thrombolytic agents.
Well, if you look at the clinical data with thrombolytic agents, the greatest advantage of the newer thrombolytic agents like tenecteplase and retiplase is the ease of giving the drug. You can give it within a few minutes to 20 minutes. So that is the big advantage of this newer therapies. With streptokinase, you have to start an infusion, you have to give up, over 1 hour. There are many side effects, especially due to the anti-streptococcal antibodies in the system of many Indian patients, because they are subject to streptococcal throat infections and you may get hypertension and stuff like that. So I think that the real advantage, more than mortality, has never been proved to be beneficial, except in the Gusto, where there was a mild advantage of TPA over streptokinase. Over the newer thrombolytic agents, we don't have head-to-head data. But end of the day, what's most important is that the ease of delivery, I think, is the single most important thing. And number two is the level of arterial patency. It has always been shown that newer thrombolytic agents have higher arterial patency than the older thrombolytic agents.
But the funny thing is that it's almost double. For streptokinase, it is 32%, and for newer ones, it is 62 to 63%. That means just double.
Right.
But what is amazing is that it has not been translated. This superiority of the newer thrombolytic agents, so far as creating the patency of the infarct-related artery, has not been translated into reduction of mortality. So, any comments about that? Really, we do benefit from the newer thrombolytic agents.
Yeah. So I think that this is a very important subject, and we assessed this in the Tamil Nadu STEMI project. We had the impact of a single thrombolytic.
What do you give over there as a routine, or majority of the patient, what they get?
Well, right now in Tamil Nadu, when we ran the project, it was still streptokinase, because government had funded 96% of the thrombolytics used was streptokinase. But now we have some data of streptokinase versus retiplase head to head, and we are hoping that the governments will move the second generation or the third generation thrombolytic agents into the government patients. The private patients obviously access because they can pay a better thrombolytic agent. Right. But I have to say that more than the type of the thrombolytic, it is a system of care which is important, because we published this in Indian Heart Journal, that if you deal with streptokinase with a good system of care, you can almost get the arterial patency which you would get with the newer thrombolytics in terms of TIMI flows and arterial patencies. So what my take home would be that thrombolytic agents are important because if the newer ones can be given quicker, but more important, if you give a newer thrombolytic therapy but without a good system of care, you will have the same disadvantages.
European Society tells that give fondaparinux along with the streptokinase. What is your opinion?
Well, we have followed very simply a concept of whichever heparin you have and can afford and get. The advantage of say enoxaparin over fondaparinux, you don't need to change it in the cath lab because fondaparinux unfortunately in the cath lab has not shown to be a great drug.
But you know, strangely, European Society has not recommended enoxaparin, probably because of the fact that both together will increase or enhance the chances of bleeding.
Yes.
So fondaparinux being a weaker anticoagulant, they want some antithrombin action in a lighter way. Maybe that's their recommendation.
Maybe that's one reason.
Because they are very clear that use fondaparinux and not enoxaparin.
Yeah, but the data with
But they
extractemy was
tell
otherwise.
along with tenecteplase you can give enoxaparin.
Yeah, I don't think this really matters, and I think what really matters is give a good thrombolytic, give it quickly, and get the angiogram done quickly. That's my take.
Even pre-hospital thrombolysis, if possible, which we are attempting to do from our STEMI Society of India, we are trying to do that. So I think that will help further because the CAPTIM trial and the French registry both have shown that if we thrombolyze the patient within first 1 to 2 hours, the mortality is even lower than primary PCI.
There are some issues of that in this country because of the legal issues. In France, where it goes on as a pre-thrombolytic system in the ambulance, there's a physician in the ambulance. Unfortunately, in India, we can't have physicians in every ambulance. So the legal issues will have to be covered before you start pre-hospital thrombolysis. But end of the day, I think the most important take is quick patient to access hospital.
Absolutely.
Get an ECG within 5 minutes, thrombolize with a superior thrombolytic agent if possible, and following that in the next few hours shift to a tertiary care because the complications movement they run in can create problems in small units, and have an angiogram done if possible within 24 hours so that you can access what is the risk to the patient and then plan. To just give you a brief that in the Tamil Nadu STEMI project of 2,400 patients, before we put the system together and after the system together, which was published in the JAMA, we found a 3.4% absolute reduction of mortality, which is a tremendous reduction for a small group of population of 2,400 patients in the Tamil Nadu STEMI project by just putting a system together. Everything else being the same, just putting a system together helps you. I think that's what we need to focus on. We need to have ambulance services, we need to have ECG facilities, we need to have good drugs in the periphery, and if possible, refer for an angiogram quicker.
Ajit, what can we do, you think, to increase the awareness among the population? Because at individual level, we have been going to TV, to print media, to radio, to different forums. We are telling, please don't ignore, consult your doctor, rush to a center where there is a good cardiac facility to reperfuse you if you have a heart attack. But still we find that our endeavor is too inadequate. So how do you think that we can increase the public awareness so that they come sharp within 1 to 2 hours as it happens in Western society?
So one is the cost effectiveness of these public health motives or attempts. Giving a television show or putting up a huge ad is hugely expensive because for a few minutes you may be paying lots of money and it doesn't make that impact for the money put in. I would possibly, in Tamil Nadu, what we are doing is very simple things. We are not spending too much money. Each primary health center has small put-ups which have in the local language in Tamil of how do you sense a heart attack, what do you do if you have a heart attack, where to go for, simple things for people. We could also use cell phones because just giving SMSs are cheap, and we could use it in a way which is educative. This doesn't cost too much, rather than too much of high branding advertising, which would be not cost effective in my opinion. in the long run. It has not proved effective in the United States, so it's unlikely to be proving effective in India. I think the Cardiology Society, the API, the Association of Physicians of India, and organizations like STEM India should take leads in putting all these actions together so that we can have a focused way of improving the access to myocardial infarction treatment.
So, do you postulate pharmacoinvasive approach, that is what you told just now, thrombolizing the patient as early as possible, and after 2 to 24 hours according to ESC guideline, we should take the patient to a hospital where there is facility for angiography and if required angioplasty, what we call as pharmacoinvasive angioplasty. So what is your experience that this pharmacoinvasive angioplasty is non-inferior to the other one, that is primary PCI?
I agree with you, Diman, that we have to have a resource-based treatment for myocardial infarction. Even in the US, parts of the US do not have access to cath labs and they thrombolize patients. So there's nothing wrong in that. So I think the first thing is from no treatment get to some treatment. From some treatment get to patients getting thrombolized. Once the thrombolysis is over, to try to get a pharmacoinvasive approach. And if those patients can get primary PCI, please go ahead and give it, because that is definitely the standard of care, but most people cannot access it in India. So there's no point saying something which is not possible to get. So I think these are the issues we need to look at this point of time, except for a very small group of patients, which are the cardiogenic shock or the patients with hemodynamic instability, where primary PCI is superior to pharmacoinvasive, with half-dose thrombolytics, safer antiplatelet therapy, a radial access, pharmacoinvasive to me is non-inferior to primary PCI.
I have two more questions to you. Number one, what are the hurdles in your working atmosphere? Because you are having an innovating new concept which is not new globally, but so far India is concerned, none of our states have such a STEMI program, which is a very active one, and you have successfully implemented it. Now, during the last few years, what hurdles you have really faced?
Well, I think the first thing is to get the government together with you. I think that it's very important that you have a public-private partnership and not do it in only the private system, because we know in the private system things are more efficient and the load of patients are much fewer than a public system. The second thing is to convince the government that investing in this, now we have a paper now coming in Global Heart which shows clearly that for every rupee that the government of Tamil Nadu invested, by improving the STEMI program and reducing the mortality, 3.4 rupees it saved. So it not only saves lives, it saves money. So once you say that to the governments, then they get involved more actively in the program.
And Ajit, how do you look that we have been working together that to implement this Tamil Nadu STEMI program to pan-India level, to all the states of India, so that all Indians can get this facility of this thrombolysis early and then pharmacoinvasive or PPCI, some sort of reperfusion, some sort of good treatment after a heart attack?
I think what we need to do is spread the message among physicians, that is one. Two, spread the message among the governments and the administrations that this is important, because this is a very clear acute problem which if you do it properly you can save a lot of lives. The third thing is to tell the governments that this is not very resource intensive. You can put this program in at reasonable cost, get a system of care together in the country, and get the Cardiology Society of India, the Association of Physicians of India actively involved in each state in trying to push this program to every part of this country. And I'm sure it's the same which happened in the US, it's the same which happened in Europe, and the same thing is going to happen in India, albeit it's getting a little slower and a little longer in this country than many of them.
I think even in USA, like in North Carolina, one very senior physician was telling in one of the HA meetings, I was chairing the session, he was telling that even there 20 to 25% of the patient are not reperfused. So this is a global phenomenon. Correct. But I think the smaller European countries are much advanced, like the Scandinavian countries, Belgium, France, Germany. Even on a snowing night when it's snowing heavily, they can go to any center within 30 to 40 minutes and get the primary PCI done. But our environment is totally different. So we have to work together and very hard work with the government, with the secretaries, with the ministers to implement this program. So how much hopeful you are that after implementing successfully in Tamil Nadu, we can implement it in a pan-India level?
Okay, so let me tell you the successes. So we have finished the Tamil Nadu phase 1, completed 2-year follow-up. The Tamil Nadu government is going into phase 2. That means they have put up 12 public hospitals with cath labs, which is very important for the public system to improve. And they're doing the same model of a pharmacoinvasive plus minus a primary PCI in all the hospitals. STEM India is partnering it. The Gujarat government has sent us an MOU for the first UN Wadia hospital with all its spokes. It's a government hospital with all its spokes. There seems to be interest from the Madhya Pradesh government to put this program together. And I think that all the cardiac societies seem to feel that this is good, and the implementation is just a question of time that we all put our heads together and get this going, because I think this will benefit many people in the treatment of STEMI.
And what about mortality? You were telling that mortality has come down significantly. So what is the present mortality at the level of the government hospitals or even in the private hospitals?
So in the Tamil Nadu STEMI project, what was very interesting to know was that the immediate in-hospital mortality was about 6.8%. But the 1-year mortality, if you did not put a system together, was about 19%. And if you put the system together, was 15.6%, about a 3.4% reduction. But what is we have done, just finished the 2-year follow-up, and it's close to 21%. So 1 in 5 people with myocardial infarction in India will die in 2 years. And this is very important things for people to understand. And this could be because the access to care is not quick. You will end up with a myocardial dysfunction. You may have, medical treatment with the medicines not being appropriately taken by patients. So many things. So I think it's not only about the thrombolytic and primary PCI. It's about bundling the medical treatment along with it. But the harsh fact is that people are younger with MI in India. They have poorer outcomes in hospitals. They have later presentations. Their 1-year and 2-year outcomes are much worse than European and American patients. So I think it's a time to wake up.
There is a huge gap between the American and Euro Heart survey, where the mortality has come down to almost 4.5 to 5%. Even they have improved, but some of the East European countries have not been able to reduce the mortality like that. So that is a stumbling block. Even after so much of hard work, the mortality is still high, and it is at an unacceptably high range. So we have to fight together to reduce the mortality. We have to increase the awareness among the population, awareness among the doctors, among the government secretaries and other level, so that we can implement this program very, very successfully under the leadership of Ajit and Thomas. He is not here today, but he is also very active, Thomas Alexander. I really congratulate both of you and all your colleagues for being able successfully to implement the program in Tamil Nadu, and we are vying to implement it from Cardiological Society of India and your STEMI India joint venture to implement it throughout India.
Thank you very much.
Thank you very much, really, Ajit.
Thank you.
He is physician in chief and director of cardiology at Department of Cardiology, Swiss Cardiovascular Center, Bern in Switzerland. His main interests are interventions in coronary devices, structural heart diseases, and TAVR, to name a few. And he is intensely involved in medical education and research. So it's my great pleasure to welcome you, Professor Stefan. I hope you had a comfortable journey from your place to Mumbai, and welcome to India and CSI Mumbai.
Thank you very much for the kind invitation. It's an honor for me to contribute to CSI India 2018, and it's a pleasure to contribute to your conference.
Yeah. Is the first time you have come to India or Mumbai?
Actually, I have been several times in India, but it's the first time that I attend the CSI conference.
Thank you very much. And to start the ball rolling, we know that coronary physiology guided coronary interventions have become the standard practice now, and we know that FFR was given a label of class 1A indication in stable coronary artery disease patients with intermediate coronary artery lesions. But still, the uptake is very low. Very few cardiologists practice FFR or physiology-guided intervention. So I'd like you to say a few words in introduction to coronary physiology, and then tell us why this uptake is so low.
Thank you. I think these are two important questions. I think, as you mentioned, during the past 2 decades, really we have seen the introduction of physiology-guided revascularization, which built on several studies in order to build evidence, which then led to a Class 1A recommendation both in the European and in the US guidelines. And I think what we need to recognize is that all these studies and evidence building took considerable time. So first there was the defer study in order to establish that actually within certain defined cutoff of FFR, back then it was 0.75, it was safe to defer revascularization. I think that was the first notable piece of evidence. The second one was then the FAME study directly comparing FFR-guided and angiographic-guided revascularization, which built the evidence that indeed FFR-guided revascularization is effective. And the last piece of evidence was the FAME2 study, which compared now an FFR-guided revascularization strategy versus medical therapy, guideline evidence-based medical therapy, and again showed a favorable outcome for the FFR-guided strategy. What I tried to say is that all these studies took a considerable amount of time, and as with any new technology, be it a pharmaceutical agent or be it a device or diagnostic procedure, it also takes time to be implemented in practice. Now, as it relates to your second question, the uptake in clinical practice, I would say yes, there isn't slow uptake, but there has been a recent survey conducted by the European Association of Percutaneous Cardiovascular Interventions, which clearly established that during the past 5 years, there was a significant increase, both for diagnostic purposes at the time of coronary angiography, but also during percutaneous coronary interventions. And therefore, I'm very confident to say that probably with more time, it will find more acceptance in clinical practice. Yeah. An obvious remaining hurdle is cost, because as anything, it requires an additional device, the pressure-tipped guiding, not guiding catheter, but guide wire. And therefore, this may be a limitation in certain settings.
Yeah. So one is the cost, and second is the time consumed, and third one is the hyperemic agents we use. So can we overcome some of these problems with something newer like IFR?
Yes, so I think the use of hyperemic agents, notably adenosine, is an important prerequisite to perform FFR, because the theoretical basis of FFR measures are to ensure maximal hyperemia, that is maximal vasodilatation of the microvasculature, in order to equate the myocardial blood flow to the coronary pressure measurements that are obtained. And therefore, adenosine is really the pharmaceutical agent that is used in order to ensure this maximal hyperemia. Now, what we have recognized is that this is also in a certain way in limitation, because it takes a certain period of time, not much, but nevertheless, interventional cardiologists are usually impatient species, and therefore this is one limitation. The second one is that a certain proportion of patients also experiences adverse events, and that lead perhaps to a premature interruption of the adenosine. And in this context, during the past few years, there has been the advent of instantaneous wave-free ratio as a concept, to use something which is analogous to FFR, that is the assessment of pressure differential during the wave-free period during diastole. And that obviates the need of vasodilator substances like adenosine. And indeed, the body of evidence that has been accrued is very favorable for instantaneous wave-free ratio assessment of physiology.
That's right. Coming back to FFR, which we still use it, do you have any preference for using other hyperemic agents? For example, we have papaverine, we have nitroprusside. Are they better than adenosine, or adenosine is the best?
I think in my personal environment, we are using adenosine, and this has a rapid onset. It is rapidly reversible when you stop the agents. It's easy to administer. And I think the important thing is that you have a standardized setup in the catheterization laboratory that ensures that you can administer or ensure maximal hyperemia in a reproducible setting.
So comparing FFR versus IFR, apart from the disadvantages you mentioned with FFR, are they equal, or is IFR non-inferior, or is it superior to FFR?
I think that's an evolving issue and subject to intense scientific scrutiny and studies. But importantly, there have been two recent prominent studies published in the New England Journal of Medicine, notably one study coming out of the Sweetheart, and the second study referred to as Define Flare. And I think both studies established that actually IFR was non-inferior to FFR. And in the context of the limitations we have mentioned before, that is certainly a strong consideration to further establish IFR in the clinical environment. Now, I think nevertheless, everything needs its time to find a maturity, and what I mentioned before, the body of evidence that has been built around FFR is rapidly building around IFR. But an important study that certainly is missing at this point in time is an IFR-guided revascularization strategy as compared to medical therapy.
That's right. And so in this transition, there are a few labs where I also involved to some extent, was you do this hybrid approach. You do IFR, the doubt, gray zone, then you go to FFR, you get a value. So if you got two different values, different values, which one were you going to choose?
Well, I think the hybrid approach has been used at a time where the confidence in the IFR measurements was still a subject of debate, and in a gray zone area, anywhere between 0.83 and 0.93, you would then verify the value with FFR measurements. But I must say, with the recent advent of the Define Flare and the Sweetheart study, this is no longer necessary. So the IFR cutoff of 0.89 could be accepted and obviate the need for a hybrid approach.
Yeah. So coming back to FFR, IFR, which are non-invasive methods, there is a CT-guided FFR, which is non-invasive method. How does it compare with these two?
Well, I think we do have only limited experience with CT-derived FFR. Actually, the algorithms actually could be also derived during the time of coronary angiography. I think there has been an initial set of studies that are rather encouraging. But I think the invasive correlation of CT-derived FFR with invasive assessment either of FFR and IFR certainly requires further scrutiny. And I think this is the interplay of two techniques. First, we also know that CT angiography is very good and precise in ruling out significant disease, but that there is a certain gray zone when it comes to intermediate or high-grade stenosis, where actually coronary angiography remains the standard of care. And I think we still need to learn more than about CT-derived FFR and invasively derived FFR in analogy to CT angiography and coronary angiography.
That's right. And do you see any problems in using FFR in the cath lab? For example, left main disease. Are there any special problems?
So left main disease is a challenging lesion for both angiographic assessment, but also physiology assessment. I think since the early days of coronary angiography, it has been recognized that intermediate left main stenoses are difficult to assess. And this really led to the advent of intercoronary imaging, where actually we have very reasonable data as it relates to intravascular ultrasound to provide us with more diagnostic accuracy. Now, there have been studies performed using FFR, and these studies certainly are helpful, but I think the practical aspects need to be taken in consideration, because usually what we need is a good calibration of the aortic or proximal pressure measurement relative to the distal pressure measurement. And in left main lesions, this requires disengagement of the guiding catheter from the coronary artery tree. And usually what you are required is to advance the pressure-tipped guiding catheter into the coronary artery. So the equilibration of the pressure-tipped guide wire is a challenge. The second one is that left main disease may not be isolated disease, but it may come with disease more downstream, be it in the left anterior descending artery or even more complicating in the left circumflex artery. And the contribution of these various lesions then to the hemodynamic relevance of the left main lesion is a challenge, a diagnostic challenge. But there are ongoing studies, and I'm sure we will find ways how to further delineate this in the future. Equally important will be the role of optical coherence tomography as compared to intravascular ultrasound in the overall assessment.
IFR also will score over FFR when there are tandem lesions or diffuse arterial lesions. Is that right?
Yes, so if you have more than one lesion, certainly one way to assess these lesions is to do a pullback during maximal hyperemia, which then provides further diagnostic information as to the relevance or the hemodynamic significance of one versus the other lesion. And I think this is an important additional assessment beyond the coronary angiography estimate.
So you can you can study the whole coronary artery physiology and co-register with the images, and you do virtual PCI with this?
Yes.
New advances?
Yes. So this is one opportunity we have in patients with multiple lesions, and it is certainly an additional feature to improve our diagnostic accuracy in appropriately identifying those lesions that require revascularization.
Do you have any sort of reservations about doing this in acute coronary syndrome setting? Because basically it does assess the microvascular pressures and function. And in place of acute coronary, for example, you're doing primary PCI, and there's another lesion of intermediate coronary nature. So will this assessment be accurate?
So this is a very good question. It's actually a frequent encounter we have. Then in up to 50% of patients that present with an acute coronary syndromes, you may have beyond the culprit lesion other lesions that may or may not require revascularization. Now first, as it relates to the culprit lesion, I think we still rely on coronary angiography, which typically identifies either an occluded vessel or a lesion that is easily appreciated and identified on coronary angiography. However, then the question arises, what other lesions need to be revascularized? And I think what we do appreciate is that patients who have more lesions have worse prognosis The more difficult question is how we can improve that prognosis and whether revascularization beyond medical therapy adds therapeutic value. Now, there have been sets of studies both using coronary angiography estimates of coronary stenosis as well as FFR-guided revascularization strategies in patients with acute coronary syndromes, and both indicate that actually early revascularization may be beneficial. But one has to recognize that these studies are limited in patient population, and I think a definitive answer we are still missing at this point in time. So to answer your question, I think it remains an important open question, and I think at this point in time we still do not know whether physiology-guided revascularization versus more coronary artery stenosis severity, or what I would refer to biological activity of stenosis, plays an important role. Because I think in acute coronary syndromes, what we have come to recognize is that these are typically pan-arteritis phenomena where more than one lesion may be prone to plaque rupture, and whether physiology as compared to, let's say, imaging-based strategies like optical coherence tomography are the best strategy, we don't know at this point in time.
And before I come to my last question, I also would like to mention even Grunzig thought of this when he started his interventions. He tried to measure the transstenotic gradient with his fluid-filled catheter system, but that had problems. So my last question is about the question of using this FFR in patients of acute myocardial, going for post-CABG, or decide on bypass surgery. Can you select the patients for CABG?
Yes. So that's again another very interesting question, and indeed there are ongoing studies to use FFR in order to determine the need for coronary artery bypass surgery, comparing a strategy of conventional angiography-based referral to coronary artery bypass surgery vis-a-vis an approach where you use FFR guidance to basically reclassify lesions that are significant or not. I think at this point in time it's premature to make a firm recommendation, but certainly if we apply the concept of physiology-based revascularization to PCI, it would also make sense to apply this approach to coronary artery bypass surgery. But I think we need more time in order to await the results of those studies.
I have an additional question on, now that you're interested in TAVR, right? So severe aortic stenosis, TAVR, what is its impact on FFR?
Yes, so I think we have to recognize that usually severe aortic stenosis is the leading problem in patients with aortic stenosis and coronary artery disease. So our strategy is usually to first treat the aortic stenosis and then to reassess the significance of coronary artery disease. We do know that patients who have both coronary artery disease and aortic stenosis have worse prognosis as compared to patients with only aortic stenosis, but the strategy as to the best therapy, whether this is a conservative approach or medical-based approach or revascularization, still is open and requires further study.
Yeah. But I seem to have read some reports where after TAVR, it might unmask some of the lesions in coronary artery when you do the FFR.
Yes, it may, but I think it's premature to make a firm conclusion. Yeah.
So I thank you very much for your answers to some of our questions, and it's been a great pleasure to interacting with you, Professor Stephen.
Thank you very much. It was a pleasure to be a guest here. Thank you.
Hello, good afternoon. I am Dr. Bhavesh Vajifdar, interventional cardiologist from Mumbai at Lilavati Hospital, and today we are going to discuss about the transradial procedures. I have been fortunate to learn transradial procedures from the father of transradial program, Dr. Ferdinand Kimenai at Amsterdam, the Netherlands. And I started doing transradial procedures right from the year 2000. And with me, I have another senior colleague, Dr. S.K. Chugh. It's a pleasure to have you here, sir.
Thank you.
And Dr. Chugh is the professor and head of department of the Jaipur National University, and he's an excellent interventional cardiologist. Importantly, he has been doing transradial procedures from the year 1997 when he first trained for the transradial approach at Toulouse in France. So Dr. Chugh, can you take us through your story, which perhaps will reflect on how transradial started in this part of the world? So can you tell us something about this?
Yeah, 1997, I was at Toulouse and I was trained by Jean Fajade, Jean Marco. And in those days, radials had just started, and France was very actively involved in radials. And I was actually working as a registrar in cardiology in London. And I went there, and then after a few months, I came back to the UK, met Dr. Jim Nolan, and he's a pioneer in the UK. In those days, it used to be 2% in the UK. Transradials were only 2%, and there was a lot of opposition even there,
Yeah.
And then subsequently, I had the opportunity to work in Canada. I worked at Victoria, which was a fully radial center, and I was amazed to see that, everything was being done radial, and hardly anybody knew about that center. So coming back to India was like coming back on a time machine, and there was hardly any radial here. I met with Dr. Tejas Patel, and maybe one or two other guys were also doing radial at that time. And slowly, we started building on our radial experience and
Yes.
Teaching people about radials, doing radial courses. We started this Radial Live, which we still do. And this year it's going to be in 2019, 3rd February at Samrat. This year it's Chip Radial.
Wow.
Chip Radial at Radial Live. And the interesting story is, when I came back to India, we were scared that if we failed, we would not be allowed to do, because as it is there was so much opposition. And so to be precise and accurate, we started doing sizing of the radial arteries, and then we started looking at the Doppler to make sure the radial was patent when we got into it. We sized our hardware accordingly. Then we started looking at the cubital fossa to see if the bifurcation was normal, so that if we found an anomaly, we would cross over to the other side beforehand. It would be like a pre-selection, pre-procedure selection. And that sort of became a theme with us, and we still do that sizing, although I don't look at that data at all.
So do you still advocate, because we do not do a radial ultrasound before doing a radial procedure?
Well,
like
I
for
think-
us, every patient, unless
You see, right now we are collecting data, although I don't look at the sizes, but the data is being collected to see if it actually made a difference to our practice. But I think it does make a difference when you are in your early days. And clearly, when I trained on those bigger arteries, in the Caucasian arteries, the Indian arteries are much smaller. The average Indian artery, radial artery, is about 1.7 to 1.8 millimeters. And most of the radial arteries in the Western world are 2 millimeters or more. So clearly it was a bigger challenge, and we did not want to fail. And so fortunately, we got a very good publication out of this, and we are kind of leaders in this, in measuring the radial artery, doing a pre-procedure ultrasound. This was published in Cath Cardiovascular Intervention in 2013.
Right.
And that was the first sheet sizing protocol which got published. And today, as you know, people are going back to it when they have to use bigger size sheets. 7 French, they still use that to make sure that they are not overdoing it, because all these instances of the avulsion of radial artery and all those kind of things happen when you stretch it too much. And of course, the spasm begets spasm. So when a patient walks into the cath lab and you see it's a short-statured lady, you know that the radial artery is going to be small. So the hazard of radial artery spasm is going to be higher. So you want to know which is the biggest artery. It could be a radial or an ulnar. So if you have the measurements, at least in that subset, you'd be able to preempt any possibility of getting into spasm and crossover or failure. So that sort of becomes an advantage in select cases now,
Yes.
even in our today day-to-day practice.
So tell me, since you are talking about spasm, in fact, of course, as you rightly said, the smaller artery, more chances of spasm. But sometimes we also see in very large guys you get spasm, and that those spasms in huge guys are more difficult to treat. So can you tell us how you prevent a radial spasm, and then if it occurs, How do you tackle it?
You know, I think the important thing is you don't want to, let's start with the puncture. I think the puncture should be the best, the first puncture is the best puncture.
Yes.
If the patient is anxious or having pain, I think we need to preempt that. You shouldn't wait for pain to develop and then start treating, because by then spasm has started, then spasm begets spasm and it keeps getting worse.
Right.
So we have our own spasm grades, which was published in Cath Cardiology.
Yes, I remember reading that. Yes.
Yeah. So so grade 3 is when you have to pause, and grade 4 is when you have to cross over. So I think it's important to keep all of them below grade 3. So when the patient walks in, you know, if the patient is short, could have a small radial. If it's a bigger guy, you know if he's anxious or not, so you pre-treat that. If he's having pain, then you pre-treat that with, we use midazolam to pre-treat anxiety and fentanyl for pain.
Right.
And then the first puncture is obviously the best puncture. And then obviously the hardware that we use, we shouldn't overstretch it. So if it's a short guy, you don't want to use 7 French straight away unless you have an idea of size. And then not too many exchanges. If you do too many exchanges, the chance of getting into spasm is more. So I think you can actually look at the guy and say, the short guy, you would probably need smaller curves.
Right.
So I would use a shorter curve catheter rather than use a bigger and then exchange.
Right.
But if the patient has aortic regurgitation, has a large aorta for some reason, then you need a bigger curve. So that kind of mindset is important, so that you minimize the exchange and minimize the risk of spasm.
So as you rightly said, the most important thing is prevention, and as you said, anxiety is one very important factor, and you try to keep the person at ease, and you try to keep the pain to the minimum. Along with that, I think one more important factor is the patient being underhydrated. So if you have a person who is fasting for a long period of time, and if he has been on diuretics, and if he is hypovolemic slightly, then do you think these patients are at a little higher chances of getting a spasm?
Yeah, because you would have difficulty puncturing, and so when you poke it 2-3 times, you've initiated that vicious cycle of spasm.
So how long does your patient fast prior to a radial procedure?
All of our fasting patients get intravenous fluid, which is managed according to the left ventricle.
But if suppose a patient is at 2, would you fast him from overnight or morning 11?
No, we give them light breakfast in the morning.
Yes.
We allow them hydration, and we also maintain intravenous fluids to prevent getting into that problem of, and then often they drop their pressures post-procedure. Some of them will have vagals, and some of them are sitting propped up. They would go into hypotension. So, we preempt that by giving them adequate fluids.
Right. It's very important because we give a lot of vasodilators to these patients, and in fact there is a lot of discussion about what kind of a cocktail to use for preventing a spasm. And I remember when I was working with Dr. Kimnai, we had a couple of publications where we used to have a machine pull back the radial sheath, and it would measure what kind of force is required to remove that. And then based on that, we made recommendations of whether to use NTG or Dilzem or what kind of a sheath. So I think it still is very important to...
Yeah, in our practice, we always use diltiazem. Nitroglycerin is only in select cases, the pressure is good. And if you think that there's more trouble, more spasm than what you would anticipate, but usually it's 5 milligram of diltiazem. And what we do is, once the sheath is in, we give that. And with every exchange of catheter, we give diltiazem. And again, at the end, once we've removed everything and the case is over, we again give diltiazem. So that has sort of kept the, I think it's helped the patency rates as well.
Right.
And, I think let's begin with another important aspect, which is forearm hematoma.
Yes.
I mean, I haven't seen a compartment syndrome in my practice of more than 16,000 cases, but then these are reported, and I think it's important to be very aware that what kind of hemostasis do you use in your practice?
Right. So I think forearm hematomas to some extent are a little common. Discoloration is very common, but compartment syndrome or something really has it, I think, is almost like negligible. Because as you rightly said, even I think in the last 18 years, more than maybe 13,000 patients, and we have not had a single patient with compartment syndrome. So I think, of course, if it happens, it could be dangerous, but I think we need not worry too much about it. The kind of hemostasis which we use has been somewhat similar since we started in 2018, because still the favorite hemostasis is just by putting a pile of bandage which is put into a bullet form and put your elastoplast bandages across it, which has been going on for years. But of course now we know that if we overdo the compression, then you could have a slightly higher chance of a radial occlusion. Of course, it being subclinical, we really don't bother too much. But now we have so many devices which we use, like we use the TR bands from Terumo, we use the dial kind of a flow which is from one of the companies.
When I came back to India, 2002, I brought along with me one of those clamps that we were using
Yes.
in Victoria, because in those days there were no devices. And so initially I started also develop the program at Bikaner Medical College, and so we used to take the clamp there and do, because one of those occasions I forgot to take the clamp, and so we managed with the bandage, and ever since we've only used bandage.
Bandages, yes.
And although there has been very little published data on this, but recently in our study called data study, which I presented at TCT this year, this was a study on distal radial versus right radial access, and we used the gauze ball bandage in both of them.
Yes.
And the occlusion rate, radial artery occlusion rate, is just about 3%, which is same as what was there using patent hemostasis in the Prophet 2 study.
Yes.
So I think it works well. It works well, and in our setup, it's very difficult to do a patent hemostasis because it's very labor intensive.
Yes.
And I think if you just loosen it and you don't have the staff to watch it, then the risk of getting into a hematoma and compartment syndrome would be very high.
What about the amount of heparin to be used to prevent radial occlusions? Do you believe in that?
Yeah, the standard practice, what we've evolved, after the EVO study, is 5,000 heparin for all diagnostics for an average 70 kg person. In people who are less than 55 kgs or who are touching more than 80-85 kgs, and then we go by according to body weight, 70 units per kg. And for angioplasty, obviously it's ACT guided. In the primary setting, we would normally not give the full dose initially. There are two ways. Initially, we used to not give heparin till we had engaged the guide, because if you cross over on full dose heparin, if you had to cross over to the groin for some reason, because if you're wasting time, then the risk of hematoma would be much higher.
So coming back to this very important issue, because this is where now a lot of people keep asking that if you have an acute MI, are you going to do a radial or not? If you ask me, yes, all my acute MI PAMIs, we start with a radial. Unless the patient is in a cardiogenic shock and you cannot feel the radial, that's a different story. So we know that we clearly have a mortality benefit when you go transradial as compared to going transfemoral. So what started as just a little bit of a patient comfort oriented program, preventing back pains, preventing discomfort during passing urine, but now it has come to a point that transradial procedures in acute coronary syndromes and in acute MIs are known to be reducing the mortality rate as compared to the similar procedure when done to the transfemoral rate. So what do you say?
Yeah, I think absolutely true. And 2017, we actually did a survey at the NIC, and we were surprised to find that only 2% of the cardiologists were doing primary angioplasty. Even at Jaipur, people do a lot of diagnostic angiograms. Almost 30-40% would do elective angioplasty. But when it comes to doing primary angioplasty, it's only a very small number. And that is, I think, still the fear of a crossover, fear of failure, fear of delay. There is data now to say that if your door to balloon time does not exceed 20 minutes, more than 20 minutes over and above what you would normally take, it is still better to do a radial because the mortality benefit is still there.
Right. So you brought out a very important point which I want to emphasize on, because many people feel that if you are doing a radial procedure, it's going to take you longer. I think there's a small learning curve where definitely you will take a longer time doing a transradial procedure compared to a femoral. But I guess if you are beyond say 20-25 cases doing a transradial, I think there is no significant difference between your procedure time if you are doing transradial versus transfemoral.
Yeah,
so I think that myth has to be...
We went through a publication in 2011. We did this consensus, which was published in JIMA. Job et al., Job and Tiffman, they wrote a paper on which and how should operators be graded in terms of increasing their complex cases. And so it would start with diagnostics, then go on to 1A, then go on to 1B, then go on to 1C. And once you are comfortable with the routine angioplasties, then you would go on to ACS. And so once you are comfortable with that, then you should take on primary angioplasty ST elevation, and then go on to the sicker ones, which is cardiogenic shock. So I think it's important that one should not embark on doing primaries right in the beginning of their practice, but once they are comfortable, and sometimes it can take years based on the number of cases people are doing. Sometimes it can take up to 10 years to become comfortable, and that is why I think the number of primaries is not that much right now with transradial access.
Well, I think the trend over here in Mumbai is slightly different, and I think most of the young guys who are trained now are radialists. In fact, we feel that they are much more comfortable doing radials rather than femorals, and I think so. So the trend for even doing primary angioplasty through radial is good in this part of the country or this city at least.
There's always been this debate about cardiogenic shock, and if you put a balloon pump, then should you be doing a radial or not, because you've already committed to the groin.
Yes.
But it has been our practice to do a radial even in patients who are on a balloon pump, and because of cardiogenic shock, because impella is hard to get, and because of cost issues. But again, the advantage of radial is there because the balloon pump comes off when the patient is stable, and by then the blood thinners have the effects have gone off. So it still makes sense to do radials in patients who are on a balloon pump and sicker ones.
So coming from the ACS and AMIs, what about the other subset of patients which have a complex lesion like a bifurcation lesion, and you need to do two stent techniques, or you have a CTO? So what kind of, are you able to do 7F procedures via the radial, and what about the newer sheets which are there?
Coming to complex PCI, we did the country's first transradial road ablation in 2002 using 7 French. But then the advantage is once you have the idea of size, if it's a 2.3 millimeter or more, then we've seen that there is not a problem because that translates into an equivalent French size. And if you had to go in a smaller artery, you're probably better off going sheathless. But the problem is when you use sheathless guide, then you can't give any more deltaism if the patient goes into spasm, and if you have to change your guiding catheter, exchange it, then there's no way you can give deltaism if the patient goes into spasm. That's a problem with sheatless. And then now you have these slender sheets on which we've done a bunch of cases.
Yes, I was going to
with the Japanese, and we've done a bunch of chronic total occlusions using 5F, and it is feasible, and we actually published that in Indian Heart Journal as well.
Right. So Dr. Chugh is talking about the new slender sheath from Terumo, which actually, if you're using a 6 French sheath, you can put in a 7 French guide catheter through it, and that reduces your chances, and you can put you can do complex cases when you want to use a 7F in a person who has even a 1.8 millimeter radial artery. And Dr. Chugh has had a good experience with that, and I think this is the way it's going to be in the future.
So outside would be 5F, but inside would be 6F.
Yes,
so that's the big advantage.
Similarly for 6 and 7.
Yeah, but you have to be careful that because those kink easily.
Very slender sheets. So these are very slender sheets, and while you are exchanging your catheters and wires, you have to be really very careful doing it, because otherwise you can damage the sheath. But otherwise they seem to be a very good boon. Coming a little to doing some problematic radial cases. So what is your experience with patients having radial angulations and radial loops and subclavian tortuosities? What do you do?
This morning I did a talk on tips and tricks.
Yes.
And, so there are two things which came out. One is that we've now moved on to distal radial access, which is now our default access. And I presented, as I said.
So can you tell us a little bit about this?
Yeah, distal radial access is when you access the radial artery through the anatomical snuff box.
Yes.
And although you have more failures, there's again a learning curve. But even after 500 cases, we still have a failure rate of around 10 to 12%. And even then, even though the failure rate is little higher than when you compare that with the radial access, because here there are angulation issues, and the hand position is very important. If you don't have an appropriate hand position, which is a little bit of pronation with a little bit of extension at the wrist, then the alignment may not be good, and so your failure rate may be higher.
Right.
But if you do that, then even then the failure rate is like 10 to 12%. The puncture time may be higher. Radial artery occlusion rate may be same as that with radial access. But even then, hemostasis is easier, because it's just a gauze ball bandage here, and there's no risk of a forearm. We did not have any forearm hematomas, though it can happen theoretically.
Right.
And so obviously the follow-up is not as labor intensive, and you don't have to do a patent hemostasis in that.
Right.
So that's an advantage of that. And if the radial artery occlusion rate is similar, then why not? So that's kind of become our default. And when it comes to crossing these tortuosities, our simple thing is if you are in a hurry, meaning if it's a primary angioplasty, we would go with a angioplasty wire, which would make it easier to cross all of that, then use a balloon on top of that and use a guide which follows on the balloon, deflated balloon, not inflated, because with an inflated balloon it's defined as a bat, but we sort of don't attribute to bat because we think the risk of extravasation may be higher, risk of subsequent occlusion of radial artery may be higher. So with a deflated balloon, you can follow up on the guide on the wire and use the same wire and balloon to do your angioplasty. So it saves a lot of time and helps you negotiate these tortuosities and bends.
True. So we can go on about radial because there's so much to discuss, but we have some limitation of time. So, but I would like to make a couple of important things for the newer people who want to start doing radials. One question which I would like to ask, do you insist on an Allen's test to look for collaterals?
No, I've stopped doing
At least in the beginning of the career? What about the beginners? Should they do an Allen's or not?
Well,
I feel that they should do, but there are a lot of my colleagues who say they don't do it. So,
yeah, I think there's no harm in them doing the Allen's in the beginning part of the stage, but we've stopped doing Allen's. But clearly, if we've accessed the radial, we would not do the ulnar on that side because that would be a hazard. Although there are case reports, but we would not recommend that.
And lastly, whenever you have a problem, though we have a lot of guides and catheters which can engage well from the radial procedure, but if you have a problem, I think one of the easy maneuvers which everyone should learn is to do a deep breath whenever there are a lot of tortuosities and kinks in the subclavians and all. A deep breath many a times helps to reduce the kinks and helps in improving the procedure outcomes. I think that's a very simple
I
thing
think it's
which
a very good
everyone
point.
should be aware of.
Coming to guides, I think you should use the guide you're comfortable with even in your femoral. If it doesn't sit well, you can pass the wire into any branch that comes, if the guide's pointing towards the circumflex and you want to do LAD, pass your wire, soft wire into the circumflex or ramus, whichever comes first. And then you can turn the guide towards the LAD if that's your area of interest, and then the wire can actually go down there.
Perfect.
So that is a good way of using any guide, and buddy wires are useful for improving guide support.
Right.
You can use additional support with a balloon also. So any case can be done using any guide, whichever you're comfortable with. It's best to increase your experience with the guides you're comfortable with rather than use fancy guides.
Right. So Dr. Chugh, to the end of it now, one last question. So in the last 20 years or so, you have seen radial evolve. So what do you say in the next 10 or 20 years? What do you think of the radial procedure? Where will we be in India?
See, I
will
think
it be the default mode?
It is already default for most people, but I think we are still awaiting data on the distal radial, and it's probably going to be time soon that people would think that distal would be considered better because of the ease of hemostasis and less risk of forearm hematoma. But while on this, I think we've missed out an important point, and which is it's very important when you do a radial through the standard radial access at the wrist, you must always keep feeling the forearm, not just looking at it, because a hematoma could be developing there. Sometimes we have a remote hematoma from a puncture from a wire, from a glide wire, by perforating a perforator somewhere. So that would be very important to keep feeling, and if you have any doubt, you should put the gauze balls along the length of the radial, cover that up with Dynaplast so that you prevent development of hematoma. That's very important. Right. And if it starts developing, you have another way is to inflate a BP cuff, blood pressure cuff, sphygmomanometer cuff on the arm to above systolic, deflate every 3 minutes for 30 seconds. And so you can actually prevent the development progression of hematoma, which is very important if you want to prevent the compartment
That's
syndrome.
really a very nice tip for the beginners. Thank you so much, Dr. Chugh, for this discussion. And we can go on, but maybe sometime other. But there is a shortage of time. I think we've had a very good discussion. Thank you so much for coming.
Thank you.
Thank you.
Thank you.
Atherosclerotic cardiovascular disease is one of the major problems in developing and developed countries. Of course, hypertension and hypercholesterolemia are two important causes for the development of ASCVD. Of course, basically, one has to change the lifestyle modification, including the healthy diet, exercise, less stress, smoking cessation are all parts of the treatment. When you come to the drugs, statin is a good drug, proven effective in hypercholesterolemia. We come across certain situations where the patient's hypercholesterolemia cannot be controlled only with statin, especially in very high risk groups. So what do the guidelines say? In a very high risk groups, when statin is not effective, we add the second drug called SMB. This SMB prevents cholesterol absorption. It is a very good drug added to statin. Suppose the atorvastatin 10 milligram plus SMB 10 milligram, the effect is like 80 milligram of atorvastatin. So it's a good add-on drug, and SMB, especially after the IMPROVE-IT trial, people started using it. It has come back. In the recent ACC guidelines 2018 November, they say very high risk group, the first drug is statin, the second drug is SMB, and third drug is PCSK9 inhibitors. The PCSK9 inhibitors are very good drug, and it can reduce cholesterol up to 50 to 60%. And there are other drugs which can also be used in case of statin myopathy, statin intolerance. As I said, if the statin is not effective, and it can be used in familial hypercholesterolemia. So I will come by one. First is SMB. I told you SMB is a very good drug, and it can be given in the very high risk group. Even in the high risk group, it is a second drug. The PCSK9 inhibitor in the familial hypercholesterolemia and in the very high risk group, it can be used, and when you don't achieve the target LDL 70, there also PCSK9 is useful. Coming to other drugs, the bile acid secretants, BAS. There are three drugs: colesilvum, cholestyramine, and cholesterol. The colesilvum is a good drug. Of course, it is not available in India. It is indicated in pregnancy class B indication, and it is also an adjuvant for diabetes. Coming to bile acid coming to the fenofibrate and FAD, these drugs in the subgroups, they have analyzed the meta-analysis of field trial, ACCORD trial. They come out to the conclusion, when a patient has got more than 204 triglycerides and less than 34 HDL, these FADs have some benefits. Fish oil, recently in the 2018 New England Journal of Medicine, November 11, they have come out with a reduce it trial, which says the sudden cardiac death, cardiac events are reduced when you take EPA 2 grams twice daily. And there are other new drugs like mipomycin, lametabide, phytol, plant sterols, and niacin. Of course, niacin is an old drug which is now banned because of side effects. After the HPS trial, the drugs are banned, and it is not very useful. So the standard of drugs, of course, statin, then comes the SMB, then comes BAS, and in certain hypertriglyceremias, FAS can be, fenofibrate can be tried, and of course fish oil also, the recent evidence is there. But overall, for any healthy life, as I first said, consider first lifestyle modification, healthy diet, good exercise. Then comes the drugs. Before you give the drugs, discuss about the benefit, cost, and of course risk ratios. In any patient, even though you achieve the cholesterol to the target level, even then they get problems, and this is what is called as residual risk. So considering all that, we can give drugs according to the patient individual priority, because if they have some other complication and if they have myopathy we'll have to switch on to different drugs. My message to the patients always is follow good lifestyle, take the drugs regularly, especially when you take statin, you have to continue till lifelong. In case of diabetes, we have diabetic dyslipidemia. Apart from all these drugs, controlling diabetes is the key, and when the patient has got hypertension, controlling hypertension is a very important thing to reduce ASCVD. Thank you for your patient hearing.